Hi, everybody. We're going to talk about talking with parents about autism. Could I have the next slide? Um, and why it's important in primary care. I want to give you an example. If you have a child in primary care and they have asthma symptoms, generally you don't say, I don't know too much about it, talk to the specialist and they'll communicate what they need. You have an active role, and the same is true in autism for a couple of reasons. First, it's actually quite common. So you do have children in your practice with autism. When I started in pediatrics, it was way before most people's time. Uh, the incidence of autism was about 0.4%, about 4 in 1,000. And it's now about 2%. That's a huge increase. Most of that is because what we formerly defined as autism was what is called level 3 autism, the very severe nonverbal form of autism. And all other forms are called something else, learning disabilities, language disorders. So, but just recognize you have children in your practice with autism. You absolutely do, unless there's something wrong with your practice. You have children with autism. The second thing is that this is a long-term disorder. This is not a short-term, strep throat and then you're better. This is something that's going to stick around a long time, has major implications for that child's well-being over a long period of time and into adulthood, for sure. Another thing is that we understand comorbidity, and other professions may not. And comorbidity in autism is the rule rather than the exception. So that's something people are going to look to us for about what else is going on. And then, parents look to primary care as leaders in child development, whether you like that or not. When you think about who has the most touches on a child professionally in the first 3 years, especially, just add up the number of well visits and think about other professionals, and primary care comes out on top most of the time. So you have a lot of view of the child, and you're supposed to know a lot about development. Parents look to you for that. Next slide. Thanks. So we're going to talk about some of these topics. I won't read them because we're going to go through them, but let's just go to the next slide. So my suggestion in terms of talking with parents is that these topics come up. There's no need to think that you need to cover every single thing about autism on every visit or one visit. But these things come up over time, and that's the wonderful thing about a medical home is you got plenty of time. You get to know the parents over several years, and you can have these discussions as you go along. So, the first thing is going to come across is what is autism and what does it mean for my child? I'm not going to give you a lecture about the symptomology of autism, but I'll share a couple of things that I think are core that you want to tell parents. Next slide. So the concern really is in that person-to-person connection. That is the number one symptom that produces disability in autism. So that's the one you really want to focus on. That sense of how does this person connect to another person? Let's see the next slide. So that comes across in two forms. One is social communication, and the other is in social reciprocity. So by definition, a person with autism has trouble communicating their ideas to another person, has trouble understanding what other people are trying to communicate to them. So it's not really a speech delay. That's what I tell parents. Yes, there may be a speech delay, but that's not the problem. The problem is a communication disorder, which is this idea of a real block in how a person understands the attempts at communication back and forth. Next slide. And that's basic to child development. So some of the things you see, less spontaneous communication. It can be quite mild. It can be very severe where the person has no spontaneous communication. Less responsivity in general communication approaches, diminished gesture, off-target verbalization. You're talking about what a nice blue sky is out there, and they might say, yeah, I like the Buffalo Bills because they have a blue color on their uniform. There's less turn taking, less unusual inflection, intonation, and different rates of speech and control of volume. Those things we call prosody are different. Those are some of the communication differences, and they all add up to say the person doesn't understand as well and doesn't express themselves as well. Next slide. And then the second thing is social reciprocity. This idea of understanding and responding to their social world. Social connectedness is another way to put it. And it is, again, one of the core issues in autism. It makes it different than obsessive compulsive disorder. It makes it different than ADHD. That's really the big difference. Next slide. So when you explain to parents the socialization differences, diminished social contact, it's not as sustained. There's less attempts at social communication. There's social aloofness. I tell parents, this is not a question of friendly or unfriendly. So people with autism can be very friendly, but they may be aloof. It can go in either direction. There may be oversensitivity and failure to observe social norms. One of the most common problems in autism is social space. So a person's in your face or just the opposite. They're really not connecting because they're too far back and they're not really paying attention to the nonverbal social cues that you're giving them with your body. Next slide. So the underlying problem in autism is the difference in processing information and then forming ideas from that information. And I'm going to go through this a little bit for you. Next slide. Okay. So here's some of the changes in information processing. So this is a simplification, but I think it holds up pretty well. You know, humans have two ways of processing information. So we all have concrete thinking, which is you classify, you put data into slots, you use very discrete information. So you say it's big, it's small, it's 3, it's blue, it's bigger, it's smaller. So you are getting very discrete information. That concrete thinking is critical from minute to minute. You have to do it. But then there's another way we think, which is seeing the big picture, coherence, abstraction. And that's where the problem in autism is. So autism really has to do with less intuitive thinking, much more concrete thinking. And when you think about socialization and communication, those human traits are abstract thinking. They're not concrete thinking. So you can say a person's eyebrows go up, that's concrete. But you say, I see the eyebrows go up, and I know that means the person is surprised by what I said. That's intuitive thinking. And that's where the problem is in autism. So that's why this information processing difference makes a big deal, because it produces the symptoms of autism. Next slide. Along with those differences, you come from great strengths. So, for example, typically or commonly, the concrete side of things is strong. So you can say, person has laser focus, details are important, they have a great memory, there's a sense of sincerity because they see things kind of more black and white, they have trouble with the gray. They may be very helpful because they see these very distinct points in time. Those are some very good strengths. An example I give families pretty commonly is let's take two children to a place that there's 100 trees. And one child might say, I see 100 trees, here's the bark pattern, there's 40 elms and 30 chestnuts, and the rest are non-deciduous trees. That's great information. The other child might say, oh, this is a forest. I know a scary story about a forest. You want to hear it? See the difference? Same stimulus, very different experience of what it's all about. Next slide. So why is autism a concern? That's a question for parents. Okay, why is it even a big deal? And I think there's some legitimate questions in our social world that say atypicality in the social realm may not be such a big deal, but that's not actually that doesn't really hold true for a lot of people. Uh, so I think we have to say we absolutely do have a basic need to communicate to other people. And if there's a problem in social communication, that's a basic problem in your ability to develop appropriately. Um, we have to have our emotional needs met. We have to understand our social role and make social connections. Maybe you don't need 30 friends, but you need 3 friends. Um, we have to make reasonable life decisions, and reasonable life decisions also include judgment and sort of planning and making great decisions, doesn't it? It's not just yes, I go to graduate school, or no, I don't go to graduate school. It's like maybe I need to go to graduate school for a year and then take a year off. Those are important things that people who are in the spectrum may have difficulty doing. Um, next slide. So how serious is autism? I think you all know. I think if we go again to that 4 in 1,000 statistic, those 4 in 1,000 have the serious form of autism where you say they are never going to be independent. They are going to need continued high level care all of their life just to keep them safe and to keep them well. Uh, but then there are people with autism who have mild issues where you say uh, they are at risk for problems in education, work, and personal life. And studies have shown this time and time again that in autism, even when it's mild, what formerly was called Asperger's syndrome, much higher rates of difficulties with personal life, higher rates of depression, substance issues, marital problems, difficulty holding a job, all of those things that you say, some marker of quality of life as an adult, they are at risk in autism. So it's a serious issue. But we can then go back and say, if we find it early, we can really try to minimize or even remove a lot of those concerns. So yes, it's serious, but if we find it early, we've got a chance to alter that course very significantly. And the data is pretty good about that we can really make a difference. Next slide. So the spectrum of autism, I'm not going to read these for you, but if you're a fan of the DSM-5 and like to read it from cover to cover, you'll know that the DSM-5 put 3 levels of autism. The first one is requiring very substantial support. So that's the 4 in 10,000, sorry, 4 in 1,000 group, where you say they just are going to need support all of their life. Next slide. Level 2 is sort of that moderate level of autism where you're saying substantial support, that there is ability to have social overtures, there is some ability to have verbalization, but it's still on a relatively simple level and is limited to basic communication and not kind of expanded communication, which we want for all our children. And then the next slide. Level 1 requires some degree of support, but it's mild. These are people who are doing well. Again, used to be called Asperger's syndrome. And typically, the data would say at least 50% of people in this situation, level 1, finish high school, go to college. Unfortunately, the graduation rate from college is not that high, but they are very capable of doing college work. So level 1 does require support. It's relatively minimal support. And then the next slide. And level 0, which is not in the DSM-5, but I want you to recognize this, and I can't promise all of these names are accurate. It's a listing I got from several different places. They came up with the same people. So some I didn't know, like Dan Aykroyd supposedly is on the spectrum. Lewis Carroll, I did know. Susan Boyle, Charles Darwin, Emily Dickinson, no doubt. Albert Einstein, everybody sort of thought that. Bobby Fischer, the chess players, again, because they're such concrete thinkers, can really do very well with autism. Bill Gates, Daryl Hannah, Stanley Kubrick. So if you watch his films, you really say, gee, maybe I see where some of that came around. And then the creator of Pokemon. I mean, that is really something to say because Pokemon's such an important part of how kids enjoy themselves if they have autism. So not everybody ends up having significant difficulties. People can be very successful. So let's go on to the next topic, which is the genetics and neurology of autism. I find this just wonderful information, and it's changed drastically in the last 10 years. So some of this may be familiar, some of it may not be familiar to you. Next slide. So, you know, I grew up in the years where autism was a psychodynamic condition. It was a problem in parenting, and the children had their difficulties, and they all needed deep psychotherapy. Sometimes you couldn't, quote, reach them, unquote, but there was the real child inside. And it was an interesting theory, but it was really debunked and has nothing to do with what really autism is all about. So you can tell parents that. I make it a point to say, you didn't do anything to cause autism. This is not a parenting issue. This is a change in brain function. That's what we're going to talk about. Just like you say, you didn't cause epilepsy because you are too harsh in your toilet training. It has nothing to do with that. So next slide. So the current concept is really different, and I need to read this because it's pretty specific. So it's a neurologic and genetic condition that changes a person's way of putting together information and experiencing life. This is the point I want to get across to parents, that it's neurologic. The reason it's neurologic is because the genetics are different. And when the neurologic differences cause a difference in how a person puts together information, and from that difference in putting together information, they experience life differently. That's what we call autism. You see the logical progression? That's what we need to get across to parents. Next slide. So where does it come from? Again, here's the logical progression put in another way. The symptoms are there because there's a difference in how the person thinks. They process information differently. It comes at them differently. They come up with different conclusions. That difference in how a person thinks is from a change in the wiring of the brain. That's what I talk about with parents all the time. The wiring is different. The connections are different. That's what we know when we talk about genetics. Most of the genetic alterations have to do with connectivity, have to do with networks. That's really where the change is. And where does that change in wiring come from? It's from a change in genetic information. And that genetic information can be heritable, or it looks like in sometimes it is epigenetic, which means the environment makes the change that causes the change in the genetic information that causes the change in wiring. A simple example is prenatal exposure to lead, which we'll talk about at another lecture. But so we know that toxins can actually change a person's wiring prenatally, and that can cause the symptoms of autism. Next slide. So if you like a gear theory, here's it presented as a gear. The genetic differences are influenced by environment, not always, but frequently. Some of the epigenetic pressures include prematurity, preeclampsia, paternal and maternal age, advanced age in either party. If you live in a polluted area, if you live close to a highway, you have higher rates of autism. So there are lots of, if you have higher rates of air pollution, you have higher rates of autism. So there are lots of genetic pressures that change the epigenetics. Next slide. Those genetic differences change circuitry, change networks. Next slide. Those networks change your thinking. Here's another example I give parents. I'm sure everybody remembers the fusiform gyrus, right? Sure. Fusiform gyrus is the face recognition center, and obviously very critical. And it's not really a large part of the brain, but it's a very important part. So it has to do with understanding facial expression and also recognizing who that person is by their face. And what we know in autism is that the actual physical structure is a little bit smaller, and also that the connections to that fusiform gyrus are abnormal. They're different than you would expect from other children. So that's the kind of changes in wiring that are present. And obviously, if you have difficulty with facial processing, you're going to have changes in your thinking. You're going to think about that person differently because you don't have that information. Parents need to know that. And an important point is that these wiring changes can occur and very frequently occur before birth and very likely during infancy. Uh, we don't really know why autism regression occurs, but my theory is that that massively changing brain goes down the wrong pathways. So it's kind of on the verge of something happening to it by 12 months, but by 15 months, the pathway is just the wrong one. The circuits go in a direction that's not good. The networks don't work the way they're supposed to, and it produces the symptoms of autism. Some of the next slide. Some of the important genetic concepts that I would want parents to know. First, genetics play an important role. This has been no longer debated. Genetic influences are the most primary influence in whether autism occurs or not. The genetics are complicated. It's not like an ABO genetics. It's not like blue eyes and red eyes, blue eyes and green eyes, sorry. It really is much more complicated genetics. It has to do with the interplay of environment, genes, and also other influences. It used to be thought, oh, all we have to do is find the autism gene. Well, it turns out there's probably several hundred genes involved in the production of autism. Some of them cross over and are also connected to what happens in bipolar disorder, Tourette's syndrome, and schizophrenia. They share some of the same genes. It gets complicated in terms of how to explain that to a person, but that's what's happening. And then also that, again, there's a connection between the genetic information and your environment. Toxins can play a role. Epigenetics clearly play a role in autism. Next slide. And here's the bottom line for parents. And this is something we emphasize all the time when we see children in development, but I would want primary care to really emphasize too, not in any way to try to influence parents about their decisions about childbearing in the future, but they should know that the risk increases, not insignificantly, if there's an index case in the family. So it goes from about 2%, 1 in 50, to about 4, double, or up to 25%, depending on the sexes of the index child, future SIBs, and how many children in the family have it. So it's not an insignificant risk. The overall risk, if you add everything together, is probably about 15%, but it can be as high as 25, even 50% if there are multiple SIBs in the family. And we absolutely work with families where there's 2, 3, and sometimes 4 children with autism. So families should know this, and they should have genetic counseling if they're thinking about expanding their family. Next slide. Okay, we're going to jump gears and talk about vaccines because people say, okay, what about vaccines? COVID has made life so much harder. But luckily, we have no negative information about COVID vaccine and autism. I'm sure somebody will make something up. The science is very clear. There's really no doubt. There's no role for vaccination to cause autism. It just is not the case. Hundreds of thousands of children have been studied in this manner. And populations of entire countries, and actually entire continents, have been studied, and there's just no relationship. Here's just one example. If some of the good studies have shown, just take a comparison of 2 countries that have different vaccine schedules, and then say, what's the incidence of autism at 15 months, 18 months, 24 months? It has nothing to do with the vaccine schedule. It's just that's the age they occur. And there's hundreds of studies like that. So if people ask me, basically, I I don't argue with them anymore, but I'm just saying the science is clear. There is no role. Any information you have that says there's a role is lacking science. That's the best I can say. Okay, next slide. So we'll talk a little bit about coexisting conditions because that comes up, and you are going to be dealing with that for sure in many different ways. Next slide. So if we use just a simple Venn diagram, we can say autism is strongly connected with ADHD. Very frequently, it can be ADHD combined type, hyperactive, and impulsive. But very frequently, especially in girls, it's ADHD inattentive type. But there's probably a 50% crossover with autism and attention disorders. So when you see particularly a 3 and a 4-year-old hyperactive boy or girl, and they're also having significant language difficulties, you better think about autism because very frequently it turns out they're connected even at that age. But a common time that they start to occur as a problem is in children with mild autism, in first, second, third grade. When you say that autism is getting better, but the academics are getting worse, and it has to do with ADHD. So you always have to have that in mind. The treatment for ADHD in coexisting autism is a little trickier because the success rates are a little bit less in terms of drug effects. So you just have to know that going in. Instead of the 80% success rate, it might be something more like 65 or 70% success rate without side effects. Academics, obviously, but not just because of ADHD. Academics is very frequently a comorbidity because think about the goal of learning. The goal of learning is to learn facts, but it's also to be intuitive, to see connections, to understand the big picture. And here's an example I give to parents all the time. I'd say, you know, in 7th grade, they might be studying American history. And one boy might be able to say, I know all the dates of the battles of the Civil War, where they occurred, how many people died, and what the weaponry was. Wonderful facts. But then you say, well, why did that battle occur? What did it mean for the war? And why did this war start in the first place? And they might have a problem with that. So education has to do with facts, but it has a lot to do with intuition and the big picture. And that's why academics can be a problem. On the other side of the equation, emotional concerns, particularly anxiety. Again, about 50% of children with ADHD, I'm sorry, with autism spectrum disorder are going to have some significant anxiety issues associated with it. There may be regulation issues and certainly obsessions. So your job as in primary care is to say, we'll take the long view. We'll see how your child is doing over time. And if really things start to go astray, let's have a bigger picture of what's going on and not just think about autism. Next slide. So some other roles that you have in primary care and obviously going to come up for discussion. Let's talk about the next slide, medications. So there is no medication for changing the symptoms of autism. That's changing the underlying neural connections in autism. So there's no treatment corrective intervention that changes that directly. So you're treating symptoms, you're treating comorbidity with medication. Parents need to understand that yes, the ADHD may be a very significant issue, and maybe you can have a significant impact on it, but it doesn't, and it won't change the underlying problem with autism itself. And because there's so much going on, there's so much comorbidity, my strong recommendation is medication should only come after other supports are in place, not before. It's a simple thing to do to sort of take out the prescription pad in the old days, but it's probably much better to say, tell me about the program first. Tell me about what they're doing. Tell me about behavior supports. What do you have for after school? Then let's talk about medication in that setting, because then parents see that it's part of a bigger opportunity. Next slide. Just some basic thoughts on medication, and these can certainly fit with ADHD too. But first, medications may not be as effective with autism as they are in other cases. There are two medications that are approved for autism with aggressive behavior or hyperexcitability, and that's risperidone and aripiprazole. Those are, big cannons, so be careful when you use them. And remember, these are growing brains we're dealing with, so just be careful. Uh, so one of the nice things about autism is that very frequently educational programs keep lots of behavioral data. They have graphs, they have, day-to-day charts. So use that data, and that will help you decide whether your intervention is appropriate or not. And as in many things, but more in children on the spectrum, there likely will be trade-offs. So I can't tell you how many times somebody's been on an atypical antipsychotic, and then they become obsessive about food. And so you have created hunger, but then the condition has created obsession about eating. And those two things are powerful to create obesity. So you have to be very careful about the trade-offs. Sometimes you have to say the aggressive behavior was so dangerous to the child or other people, you have to do it. Uh, but the trade-off can be pretty significant. Next slide. Okay, alternative interventions. This study is a little bit old, but I think it still holds that somewhere just south of 50% of parents try alternative interventions in autism. It is almost the rule. So just recognize it occurs. Very frequently, they don't talk about it. They just do it. And so you just need to be a voice of reason. I don't always yell. Certainly don't yell at parents. I just say, I wish I had more evidence that what you're doing is helpful, but there's just not that much. Um, there are no research, reliable, evidence-based treatments that target the core symptoms of autism. There's no quick cure, so people need to know that. There's no diet, there's no supplement, there's no acupuncture, there's nothing that treats the core symptoms of autism, except intervention services, applied behavioral analysis, appropriate education, speech therapy. Those things make a difference. They've been well shown to do that. We just don't have medicine to do it. I think you need to weigh the burden of the treatment versus the benefit. So, for example, it's still relatively popular. It's less than before that people want to try a gluten and casein-free diet. It's a pain in the neck to do that diet. And recollect, if a child already has very restricted diet, which is a very significant population in children with autism, and you take away their gluten, you may have taken away 50% of their calories. So you have to be very careful about that. And I would say the data about gluten sensitivity and autism, that question has been asked for about 60 years now. So there was even in the 50s and 60s, there was a concept of gluten-induced autism. But after that period of time, there's still no direct proof that gluten causes or exacerbates autism. There may be a lot of anecdotal information about it, but there's really no proof. As a matter of fact, the best studies that have been as blinded as you can in a gluten-free diet have shown no effect at all. So I don't push it. I just say if you're going to try it, recollect you want to really be careful about the total nutrition package. There can be risky treatments that are costly in addition. So some folks offer chelation or IVIG or stem cell therapy, completely unproven therapies that have an element of significant risk associated with them. So I'd say, if somebody is saying, well, this is the best treatment, follow the money. And if it's cost a lot of money and is proprietary, say, I'm a little suspicious about that. And then I would ask parents, where do you put your energy? And if your energy is going to be getting chelation therapy, IVIG, and following all these alternative therapies, you're not going to have energy for kind of the basic things that we know do work. So I would point that out to parents. Next slide. Inconclusive treatments, this is only a partial list. I just put them down because it filled up the page. Dietary supplements used to be hyper doses of B6 were recommended, and then kids developed neuropathy, so thankfully they cut back on that. Dimethylglycine has been a common one in the past. The diets, oxytocin has been used as a possible thing, and there is some research about the effects of oxytocin in the autistic brain. Got a long way to go, so it's not really a good intervention. Hyperbaric oxygen. So yes, you can find online hyperbaric sites that treat autism, and and so God bless the eardrums, if nothing else. But it has to be, you have to be very careful about hyperbaric treatments. Chelation is still on the list. Just sort of blast kids with chelating agents and get rid of the toxins, whatever they are. IVIG has been used, acupressure, brain mapping, and a whole bunch of other ones. Next slide. Okay, this is just a general comment when people say, well, I just want to try something natural. Just recognize if something has an actual effect, the reason it has an effect is because it has a pharmacologic property. That's not natural, that's pharmacologic. So yes, we could use deadly nightshade for heart failure, and you might make things a little bit better because of the digitalis effect. But I'd rather have purified digoxin myself. So I just tell parents, supplements generally are safe, but recognize that they are not FDA inspected, that they're sold as nutritionals, and what the dose on the bottle claims and what the dose actually is can be completely unreliable. Next slide. So we're going to wind up by just talking about how do you get kids better? Because that's what parents want to know from primary care. It's like, okay, here's some background about what's wrong. Now, how do we get them better? Next slide. So I think you can help parents with a plan of action. And here's some big concepts, particularly in young children where they're first encountering the diagnosis and sort of trying to figure out what to do. You can say without any qualms, the evidence behind early intervention is very strong, that it makes a difference, that the severity of autism frequently goes down. It may not disappear, but it can make things a whole lot better. So a nonverbal child can have some verbalization. A child who's mildly verbal can be pretty communicative after a while. So the first plan of action is to find early intervention, get the best services possible, and keep going with them. The second for the family and the child is to sort of say, there's plenty of support in the field of autism. We'll talk a little bit about that. So find it, use it as appropriate for that child. Cover the family with support as much as they want, as much as they need. So that's the general concept of the plan of action. Nothing hard. Next slide. Some general thoughts for families that I would want to include in my discussion with them if I was in primary care, which I do actually in my primary care office. So first is they need to do some reading therapy or internet therapy with reliable sources. So they should learn from soup to nuts about autism. If your child had leukemia, you'd be on the internet, you'd be reading books, you'd be finding the best authors to really get the information. The same is true for autism. And so parents deserve to have that kind of information. There are websites I'll show you in a minute. Some are pretty reliable, some are not so. But the reliable ones, I think, will give people good information, place to go. The CDC is always in the news with COVID right now, but they're actually a very good source of information for families and autism. It's an evidence-based site. They really work hard to make it readable. There's good references. So it's just dialing into the CDC is a good place to start. I recommend parents use evidence-based interventions. That's early intervention. At home, parents can sort of take the approach of like, Johnny doesn't talk much, so we stop talking to him. And that's exactly the opposite. What you want to do is be highly communicative and really encourage play and socialization, even though it may be difficult for that child to do it spontaneously. Um, a thing parents really do well is understand that the end product. For some parents, you might say the end product is only good if it includes graduate school. But most parents would say the end product is good if my child is happy, if they're productive, if they're safe, if they can take care of themselves. And those are the goals that I think we can agree on very quickly to say, you want to do your best to give that child a sense of independence, dressing, safety issues, and parents are really good at doing that. So they need to be complimented and encouraged to continue to do that. And then finding support. I think again we'll talk about some of those support areas. Next slide. Okay, just by age, I think you know all this, but I'm just going to put it very specifically so that you can say some of this to parents. Children under 3, the early intervention program is the best place to start. That's your county office, the county that they live in. That's where they're going to get the early intervention support. Counties can take referrals from any primary care provider, but they just as well take referrals from parents themselves. And most of the time, I really want parents and child, so I ask them to make the referral to early intervention themselves, and they're fine to do that. The system's pretty friendly, so I think that's a good place to start. Early intervention for children under 3. Next slide. And then recognize children 3 to 5 who are not in kindergarten yet. Nationally and certainly in New York, the responsibility for those children falls on your local school district and no longer early intervention. So it's unfortunate because I think it should be much more seamless. But at 3, the school gets involved, they do their own evaluation, and then they provide the services. And most importantly, they pay the bill for the services. That's why it's so important. And there, the parents would call their local school district office and ask for the preschool committee. The process can be relatively seamless, or it can be difficult. COVID made a mess of preschool assessments, so kids were waiting in line for a long time, much more than they should be. That's starting to sort itself out right now. Next slide. Parents may want to think about private resources. So in addition to the public systems of early intervention and the school system, there are private providers that take insurance, speech, OT, PT, and then ABA. If you're not familiar with that, that's applied behavioral analysis. So those are psychologists who are trained in treatment of autism using behavior modification. And New York State has their insurance regulations say most insurances are required to pay for ABA services unless you have Medicaid. I don't know why they're discriminating, but the Medicaid office still is not paying for that, which is a major problem for our children in this state. So they can do an internet search by location. You can call our office and we can give you a listing of people. We know most of the region, so we can probably help you out some. But private resources for some families with good insurance can be very helpful as an additional resource. Some parents are interested in doing that. Next slide. Some parents want to be involved themselves, and I think that's always a good idea. So one way to do that is recognize programs, and I've listed a few here. The Center for Autism here in Albany at SUNY Albany is a good source of information. They have a parent education program. In the Mid-Hudson area, it's the Center for Spectrum Services. And then I gave you 3 websites there. One of them is called Help Is In Your Hands, which is a website that does video training for parents. I think it's 12 video sessions where they learn how to be therapists themselves. And for folks where you say therapy options are pretty limited, it's a great opportunity for parents to be involved. And in addition, some parents just really want to be more involved. And that's an evidence-based, nationally recognized program. So it's a good program to recommend to parents, and it's completely free. And there's a few other ones there too. Next slide. I want to emphasize if a child has Medicaid, they can be involved with a children's health home. Those organizations provide free case management in a way, hopefully, that can be very helpful to parents. So, for example, just today we had somebody who was uncertain about the Social Security system, was having difficulty getting their child into preschool, didn't know anything about Office of Persons with Developmental Disabilities, New York State. And a children's health home can help in all those areas. They would help them get SSI. They would be sure they're getting the right programming, and they can help move them on to OPWD eligibility and services at some point in the future. So I strongly recommend children's health homes. You can just look online. There's multiple organizations that offer it. But the child just has to have Medicaid to be eligible for that. Next slide. If parents just want more local information, there's quality sites online and locally too. So the national ones are Autism Speaks, the Autism Society, which has a strong local branch, and as I said, the CDC. Autism Speaks and the Autism Society have been around a long time, and most of what they have online is vetted and good. There's some things that I might not agree with, but for the most part, I think I would say that they're really reputable sites and a good place for parents to go. Next slide. New York State Help. I think most of you are familiar at some level with Office of Persons with Developmental Disabilities. That's the state level support system. Anybody in the entire state who has developmental disabilities, Down syndrome, autism, for example, can get extra support. There's money available for things that are not covered by traditional insurance. For example, if somebody said, my child's doing very well with a communication device, a fancy iPad with very special software, they would help pay for that. So that's a very good organization to connect to. It's a state agency, and they're supposed to be friendly, and honestly, they are not. So the paperwork can be very burdensome. It may take anywhere between 6 months and 12 to 18 months to get through all that paperwork. So low resource families especially may have difficulty doing it. So that's why using a care coordinator can be very helpful before they get to that stage. Next slide. And then locally, here's some opportunities for parents. Some parents like to talk with other parents who have a child with a similar issue. Other parents do not. But here are some good parent organizations. The Parent to Parent of New York is throughout the entire state of New York, as is the Autism Society. But the Autism Society in the 518 area is quite strong, and they have lots of good services for parents. Things like, I want my child to play soccer, but I want him to have a good experience. So I'd like to know about what soccer leagues really are friendly toward children on the spectrum. That's a place they could find that. The Upstate Autism Alliance is a North Country a family group that can be very helpful too. Next slide. You don't have to read this, it's too small, but if you, there's a push toward care plans in primary care in general. And here is an example of a care plan that's just a one-pager for children with developmental disabilities. It's certainly easy to fill out and to use as a guide for parents. It's available downloading from the Academy of Pediatrics. You'll be able to get these slides and these references within a little while when we upload the slides to our website. So that's a good resource for you to use. You don't have to use it, but if you want a pre-made care plan, here's one you can use. Next slide. And then finally, this is a shameless pitch. Capital Care Developmental Pediatrics, that's the group I'm in. We've been around a long time. We are completely happy to talk to anybody for a curbside consult. for a question, it doesn't really matter. We love to hear from primary care. That's our first love. So please don't hesitate to call us. We've seen all manner of children with all complicated things, so don't hesitate to call on us. We'll try to figure it out with you. And if we can't, we'll find the right place for you. So I'm going to wind up by saying, when I started, people called autism the A word. They didn't want to say it to parents. They would say almost anything else: slow, delayed, disabled. They didn't want to say autism because it was the kiss of death. And I'm going to ask you not to do that, to say, yes, this is an uphill challenge, but it's a challenge that the parents can meet, they can do something about, you can have some positive results. So just keep that in mind. Don't hesitate to talk to parents. Call us if you need us. And I'll end right there. So thank you very much, and I'm happy to take questions. Alexis, do you want to mute people? How do you want to do it?
So you can either write it in the chat. I don't see any questions in the chat just yet, or please feel free to unmute yourself if you want to ask a question that way. That's completely acceptable. So I don't see anything in the chat just yet. I know it can take a little bit of time to type, so.
Hi, it's Dr. Schackenberg. Can you hear me?
Yes, hi.
Hi, Eric.
Hi. So what's your view on pets in home and kids with autism?
Did you say pets?
Pets, P-E-T-S, pets.
Yeah, okay, not a pet scan, a real pet.
Real pet.
Okay, so there's 2 points of view. First, I think the clinical impression is that overall they're quite helpful. That and the old therapeutic way of thinking is that the first stage of forming relationships with humans might be to form a reliable relationship to a pet. I think that's reasonable. So I'm not opposed to it. The second point of view is that there can be an element of concern and safety because children with autism may not read a pet's signals that they're disturbed, they're unhappy, that they're doing something that the pet is not in favor of. And so I'm always concerned that it might be the most docile pet in the world, but if a child with autism is just very persistent, and something could go wrong. So overall, I feel very positive about it, particularly in family pets that have been around a long time, that they know very well. And I know it's a pretty strong movement to have pets as therapy assistants. And I'm honestly not a dog person, but I have seen strong relationships occur between the animal and the child. So I think it might be a reasonable consideration for a lot of kids. Don't let it get out that I'm not a dog person. That's all.
I have another question. We're using the MChat still, right? Is that still the right thing to do at 15, 18, 24 months?
Yeah, it's the most popular. There are some other screening tools that are actually better, but they take a little higher level of background training, and they're a little bit harder to score. So I think the MChat is reasonable. The screening statistics behind it are fair to good. They're not perfect, but they're pretty good. And certainly, the important part of it is that it gives a parent a chance for discussion and the provider a chance for discussion. That's how I use it, is to sort of say, besides the score, tell me about the fact that they act like they're deaf. What does that mean? So that can be a very good approach. So I'm fine with it. There are other screening tools. I can send you a list if you want. Just put it in the chat, and I'll try to remember to send it to you.
So there is a question in the chat. When referring a family to a developmental pediatrician due to concerns, what is an estimated time for them to expect to get in for an evaluation and possibly a diagnosis?
Sure. Okay, I'm going to answer that in 2 ways. First of all, I want people to recognize that a referral to early intervention is a referral for intervention services. It is not for diagnosis. So I'm completely in favor of when there's a concern is voiced by a parent or a provider that you get an early intervention involved right away. There's no need to wait, and we can clarify what this exact problem is over time. But in the meantime, the child's receiving services, but they in no way are interested or capable of doing diagnostic work. So just recognize referral to early intervention is not a referral for diagnosis. It's a referral for intervention only. Uh, and as far as developmental pediatrics is concerned, I'm not going to make excuses, but I will give you some background information. Currently, there's about 700 developmental pediatricians in the country. Last year, they only had 30 candidates apply for fellowship positions, and somewhere between 50 and 80 people retired. So the amount of developmental pediatricians in the country is very small. It's one of the smallest subspecialties around, particularly given the size of the number of children with disabilities. It's a highly understaffed field. So that produces naturally long wait times, which is really difficult for us to do. But we worked really hard in capital care developmental pediatrics to change that. So currently, honestly, it used to be between 6 months and 9 months time for a first appointment, which is terrible. And now we've got it down to about 2 to 3 months, using more telemedicine, using advanced care level providers, and we actually have expanded our pediatrician, developmental pediatrician group to include more people. But we still have a ways to go. So the best answer I can give is that if you are very concerned there's something urgent, and the younger the child, the more urgent I think it is. If you call us, we'll squeeze them in. We'll put them somewhere. We'll see them at lunchtime. We'll do whatever we can to get them in soon. But the average wait time right now in our office is between 2 and 3 months. If you go to Syracuse, it's over a year. And that's actually the case in most developmental practices in the country. I can't tell you what it is at Albany Medical Center. I just don't know.
Thank you. I don't see any other questions in the chat, so anybody else on the line, if you want to unmute and ask any questions, feel free. While we're waiting for the last group of questions to trickle in, if anybody wants to comment on the best time of day to hold these, I know we were talking about this before. We polled a group of practitioners previously, and 6 p.m. weeknight seemed to be most popular. If any of you feel like a different time or day would be better, feel free to write it into the chat, email us afterwards, say it aloud, whatever makes sense for you. We are interested in your feedback always.
And then I will add that I am really embarrassed because I forgot to say this at the beginning. CDPHP has been a partner in producing these, and we're very pleased that they are helping us with getting the word out and also supporting us slightly financially just to produce the materials. And we have one more in this series of developmental presentations that will be on December 9th, also at 6, unless we hear differently from a lot of people. It's another Thursday, and that's going to be on an update in lead poisoning, particularly related to development. The attitude from a lot of people is like, that's not a problem anymore. And the answer is, yes, it is. Feel free to join us then. We're very interested in getting feedback about the topics. We're really hoping to have another series of developmental presentations in 2022, but this will end our presentations in December with this discussion about lead poisoning.
I think that's it for the questions, Dr. Malone.
Well, I appreciate everybody being available at 6 at night. Again, it's lunchtime, breakfast, 5 o'clock. It's really hard. I'm happy to do it just about any time. So we'll keep listening and see if people want to change. Otherwise, we will plan for the next one at 6. That will be the last one in the series. Please go ahead and get your CMEs all set up for that. And thank you so much for coming. and have a great evening and have a nice supper. Bye, everybody.